Welcome to this deep dive, where we unpack the latest research to keep you well informed.
Glad to be here.
Today, we're zeroing in on a really critical area, managing complications after heart valve procedures.
Yeah, this is vital stuff. We're drawing from a big state-of-the-art review in EuroIntervention 2025.
Right, the management of complications after valvular interventions paper.
It's so relevant because, well, we're doing so many more transcatheter procedures now. TAVI, M-TEER, TMVR.
Exactly. And understanding how to handle the potential issues, the complications, is just paramount for good patient outcomes.
Absolutely. Even if the individual risks get lower with better tech, the sheer number of procedures means we have to be prepared.
So our goal today is basically to give you a clear rundown of the main complications covered in this review.
What they are, how to maybe prevent them, and the latest on treatment.
We'll focus on those three main ones you mentioned: TAVI, transcatheter aortic valve implantation.
M-TEER, that's the mitral transcatheter edge-to-edge repair.
And TMVR, transcatheter mitral valve replacement.
Okay, let's dive in.
Let's start with TVI, and maybe the most dreaded complication, stroke.
Yeah. The review puts the incidence around 2.3%. Doesn't sound huge, maybe.
But the impact is massive. It links stroke to a 6-fold increase in 30-day mortality.
6-fold. That really underscores how serious it is.
So what puts patients at higher risk? It's not just one thing, is it?
No, definitely not. The review lists quite a few. History of stroke, or TIA, obviously. Advanced age. Peripheral vascular disease, so issues with leg arteries. Atrial fibrillation. Longer procedures. And, needing balloon post-dilatation after the valve goes in.
Okay, so prevention. What can we actually do?
Well, a big focus is on cerebral embolic protection devices, CEPs.
Like little filters.
Exactly. Designed to catch debris that might break loose and head towards the brain during the TAVI.
The Sentinel device is the main one in the U.S., right? FDA approved.
It is. And the protected TAVI trial looked specifically at that big trial, 3,000 patients.
What did it find? Did it slash the stroke rate?
Interestingly, no significant drop in the overall periprocedural stroke rate. But, and this is important, they did see a lower rate of disabling strokes in the group that got the CEP device.
Oh, okay. So maybe fewer severe long-term consequences. That's still a win.
Definitely a win. The review also mentions the Trigard device that's got CE approval in Europe.
And there's an ongoing UK trial, too, BHF Protect TAVI.
Right. So the research is still very active in this space. There's a useful table in the paper summarizing the different devices and studies.
Good to know. But what if a stroke does happen? What are the treatment options?
It ranges. Could be conservative management, just monitoring, or thrombolytics, clot-busting drugs.
Or actually going in to get the clot.
Yeah, mechanical thrombectomy. The paper cites some data on mortality for each approach.
So with a caveat, right?
Yeah, the sicker patients might have been more likely to get the more aggressive treatment, so it's hard to compare directly.
Makes sense.
Yeah.
But there was some registry data suggesting intervention helps.
Yes, an international registry found higher odds of disability-free survival if patients had neurointervention to remove the clot compared to just conservative management.
Which really highlights how crucial early recognition is, spotting those stroke symptoms fast.
Absolutely critical. Every minute counts, which ties into the procedure itself.
How so?
Well, the idea of using conscious sedation, keeping the patient more awake.
So you can spot neurological changes quicker.
Potentially, yes. And then there's the whole balancing act with anticoagulation during the procedure.
Preventing clots versus causing bleeding.
Exactly. Managing heparin based on ACT levels, aiming for that 250-300 second range. And sometimes using protamine to reverse it afterwards.
Okay, let's shift to another common issue, post-TAVI, conduction disturbances.
Right. Needing a permanent pacemaker PPM or getting new left bundle branch block, DEL-BBB.
And this really comes down to anatomy, doesn't it? Where the electrical wiring sits relative to the valve.
It does. The left bundle branch runs, well, pretty close to the aortic valve leaflets, especially near the right coronary cusp.
So putting a valve in there can sometimes interfere.
Precisely. And the rates of needing a pacemaker, they vary quite a bit with the newer valves. The paper says anywhere from about 2% up to, 36%.
That is a huge range. What flags a patient as higher risk on their ECG beforehand?
The biggest predictor is pre-existing right bundle branch block. That's the strongest one.
RBBB. Okay.
Also things like left anterior hemiblock, first-degree AV block, or even pre-existing LBBB can increase the risk.
Does the type of valve matter?
It seems to. Self-expanding valves, or SEVs, generally have higher rates of LBBB and pacemaker need compared to balloon expandable valves, BEVs.
Interesting. And anatomically, what makes someone more prone?
Calcium below the annulus or in the LV outflow tract, implanting the valve quite deep, quite low down, and having a short membranous septum, that thin wall near the conduction system.
Right, but in valve procedures tend to have lower rates.
Yes. Interestingly, PPM rates are often lower when you do TVI inside an old surgical valve.
So prevention strategies, what does the review suggest?
Well, for patients already with RBBB, maybe leaning towards a balloon expandable valve.
Okay.
Some newer self-expanding valves, like the Accurate Neo2, are designed with lower radial strength, which seems to help.
Less outward push.
Sort of, yeah. And then there are implantation techniques, high deployment, using what's called the cusp overlap view with the Sapien S3 valve.
Cusp overlap, how does that work exactly?
It's basically a specific X-ray angle, often involves rotating the C-arm that gives a view where two of the aortic valve cusps seem to overlap. It helps position the new valve very precisely, aiming higher away from the conduction system.
Clever. To avoid hitting the wires, essentially.
Pretty much. And another technique is implanting the valve so its lower edge is above the bottom of that membranous septum. The MIDAS study looked at this.
And risk scores. Can we predict it?
There are scores being developed, yeah. The review mentions Prime and Emory scores trying to estimate that PPM risk.
So if a conduction issue does pop up after TAVI, how's it managed?
Often, they'll do a rapid pacing study right after the procedure, passing the right atrium.
To see how the heart responds.
Yeah. If the conduction starts to block at relatively low pacing rates, what we call Wenckebach, that suggests a higher risk, maybe needing a pacemaker.
And if it doesn't block even at high rates?
That's got a good negative predictive value. Means a pacemaker is less likely needed.
And there's an algorithm in the paper.
Yes, a helpful guide based on the post-TAVI ECG changes and any pre-existing issues, suggesting monitoring duration or PPM indication for different groups.
Okay, good. Let's move to vascular complications.
Yeah.
The good news here is rates are down.
Definitely down, around 6–8% in recent trials, which is much better than historically.
Better tech, more experience.
Both, I think. But they still happen, and they can increase mortality and hospital stay, so still important.
Where do they usually occur?
Most commonly at the access site, usually the femoral artery in the groin. Failure of the closure device is a big factor.
Who's more at risk, patient-wise?
Risk factors include being female, older age, obesity, having peripheral vascular disease already, and vessel characteristics like lots of calcium, or if the arteries are very twisty, tortuous.
And procedure-related risks.
Using larger sheaths, definitely, and a high ratio between the sheath size and the artery size itself.
So prevention hinges on planning again.
Absolutely. Detailed pre-op MDCT scanning of the iliofemoral arteries is just crucial.
What are you looking for on the scan?
Vessel size, tortuosity, calcium burden, where the artery branches, all of that.
And if it looks tricky?
Well, if there's heavy calcium right on the front wall or the artery branch is really deep, a surgical cut down might be safer than a needle puncture.
Or using a different access site.
Like transradial, through the wrist, yeah. That's an option sometimes.
And during the puncture itself.
Using real-time ultrasound guidance plus fluoroscopy helps hit the right spot, and careful use of vascular closure devices, VCDs.
We hear a lot about pre-closure techniques.
Right, using things like Prostar XL or Proclose ProGlides before the main sheath goes in. Sometimes even just a single Proclose works.
What about plug-based devices like MANTA?
The review mentions MANTA, but it also notes the Choice Closure trial found higher vascular complications with MANTA compared to ProGlide.
Okay. And just using one leg for access.
The unilateral sheath strategy, yeah. The idea is it might make managing any potential bleeding complications a bit simpler.
So if a complication does happen, say a dissection, a tear in the artery lining.
If it's asymptomatic, maybe just watch it. If it limits flow, then angioplasty, maybe with a stent.
What about a full rupture?
That's an emergency. Reverse anticoagulation, get a balloon up there to block the bleeding, and often needs a covered stent or surgery.
Bleeding or hematoma at the puncture site.
Compression usually works. If it's large or expanding, maybe prolonged balloon inflation inside the artery. Don't delay treatment waiting for a CT if the patient's unstable.
Pseudoaneurysms, those false sacs.
Small ones, monitor. Larger ones, maybe ultrasound-guided thrombin injection to clot it off, or covered stents again.
And if the artery gets narrowed or blocked, stenosis or thrombosis?
Balloon dilatation for stenosis. For thrombosis, getting the clot out thrombectomy, then maybe angioplasty.
Okay, let's talk paravalvular regurgitation, PVR. Leaks around the valve.
Yeah, thankfully less common now. Better pre-op imaging with CT helps size the valve right, and the newer valves have sealing skirts.
So incidence is down below 5%.
In many recent studies, yes. Assessment involves echo, looking at pressures like the AR index, maybe aortography.
Distinguishing between leak around the valve versus through it.
Exactly. Prevention comes back to that accurate CT sizing. Avoiding undersizing is key.
And the valve design helps.
Definitely. Those sealing skirts on valves like SAPIEN 3 Ultra, Evolut Pro Plus, Navitor Accurate Neo 2 are designed specifically to minimize PVR.
If it still happens, what's the approach?
Mild PVR, often just conservative follow-up.
But moderate to severe.
If it's causing problems, LV enlargement, heart failure symptoms, hemolytic anemia, then intervention is usually needed.
What kind of intervention?
Well, temporarily, high-rate ventricular pacing and sometimes reduce the leak, definitively.
Expanding the valve more.
Balloon post-dialization can work if it was undersized, but you have to be careful if there's lots of calcium.
What if it was just placed wrong?
A valve-in-valve procedure might be an option, implanting a second TVI valve inside the first. Need to consider valve height and coronary risk, though.
And if the leak is due to calcium, preventing a good seal.
That's where percutaneous PVR closure plugs come in. Devices like M-TEER plugs can be delivered via catheter to plug the gaps.
The Lands Registry compared options.
Oh, it did. Compared redo TVI plugs and just balloon valvuloplasty. Found that actually doing another TVI tended to result in less significant PVR long-term compared to using plugs.
Okay. Annular rupture. Rare but really feared.
Less than 1% incidence, but mortality is high, like 50% if it's contained, over 75% if it's uncontained.
What increases the risk?
Heavy calcium below the annulus and the LVOT. Oversizing a balloon expandable valve, especially more than 20%.
Aggressive post-dilatation, too.
Yes. Also bicuspid valves, shallow sinuses of Valsalva, and a small native annulus to start with.
So prevention is all about careful sizing again.
Meticulous MDCT sizing, avoiding significant oversizing, maybe using a sizing balloon if CT is tricky.
Considering valve type.
Maybe favoring self-expanding valves in some high-risk anatomies. Maybe underfilling balloon expandable valves slightly. Implanting a bit higher if there's nasty LVOT calcium.
And treatment if it happens. Depends if it's contained.
Exactly. Contained rupture. Maybe conservative reverse anticoagulation, give blood products, monitor closely.
Uncontained rupture, leading to tamponade.
That's immediate pericardiocentesis to drain the fluid. Reverse anticoagulation. Autotransfusion might be used.
Surgery often needed.
Often, yes, if bleeding isn't controlled. Primary repair, annuloplasty, maybe even a full root replacement.
Can another TVI valve help?
Possibly. If the rupture site is clear, it can sometimes seal the defect. A study by Tomei looked at outcomes based on strategy.
A coronary obstruction. Another infrequent but serious one. Higher risk in valve.
Yeah, less than 1% in native valve TVI, but maybe around 2.5% in valve. Mortality is high, around 50%.
How does it happen?
Either the new valve directly pushes the old native or surgical leaflets over the coronary opening.
Oh.
Or, particularly with narrow sinuses or a narrow sinotubular junction, the valve seals off the sinus, preventing blood flow into its sinus sequestration, usually affects the left coronary.
High-risk anatomy features.
Low coronary height, narrow sinuses. In valve, surgical valves implanted supraannularly or those with narrow sinuses are riskier. Specific valve types like mitraflow, trifecta.
And distance matters.
Yes. A short valve to coronary distance, especially a KD to 4 millimeters in VV, is a red flag. And it can happen later too, delayed obstruction.
Prevention is key again. CT assessment.
Critical. Identify high-risk patients upfront. Maybe surgery is the better option for them.
But if doing TVI,
can use valves that are recapturable, like Evolut or portoconeviter, or open cell designs like Accurate Neo or Navitor.
Prophylactic wiring.
Yes, putting a wire down the coronary, maybe with an undeployed stent ready to go, the chimney stenting technique, sometimes just a balloon for protection. Use strong stents if you deploy them. And basilica.
Intentional leaflet laceration, yeah. Using RF energy to split the native or bioprosthetic leaflet before valve deployment to create space. Very important technique.
Game changer for some patients.
Absolutely. There's even BA basilica for redo TAVI and other novel electrosurgical techniques being explored.
If obstruction happens during the procedure.
If there's no wire down.
Yeah.
Quick cannulation and balloon angioplasty is the first step.
If there is a protective wire.
And usually deploy the pre-positioned stent, the chimney stent.
Other options?
Electrosurgical laceration of the leaflet after it's obstructing. Snaring and pulling up a self-expanding valve slightly. Need hemodynamic support like ECMO early.
And surgery as backup.
Emergent bypass surgery if percutaneous options fail.
Valve malpositioning. Sounds like it's thankfully rare now.
Extremely rare thanks to better delivery systems. If it happens with an SEV, might be able to snare and reposition it.
BEV.
Usually requires putting a second TAVI valve inside the misplaced one. Need to watch for coronary obstruction then. Extreme cases might need surgical removal. Last one for TAVI. Acute kidney injury, AKI. Incidence down, but still impacts outcomes.
Yeah, contemporary rates are maybe around 10%. Stage 3 AKI, only 1%. But stage 3 AKI is linked to a big jump in mortality.
Main risk factor.
Baseline kidney dysfunction is the strongest. Also anemia, diabetes, COPD, vascular disease.
Procedure factors.
Hemodynamic instability during pacing, bleeding, maybe embolization of tiny fragments to the kidneys.
Prevention.
Hydration.
Adequate prehydration, yes.
Yeah.
Maybe using the renal guard system. Big focus on minimizing contrast dye.
Oh.
Using MRI or 3D TOE for planning instead of CT sometimes. Non-contrast CT for root access assessment. Low contrast volume protocols. Gated CT to see coronaries might avoid invasive angio.
Near zero contrast procedures.
Using echo, gadolinium-free CMR, fusion imaging, diluting contrast, holding nephrotoxic drugs, checking access site with ultrasound at the end. Careful post-TAVI angiography, especially in CKD patients.
Okay, let's switch gears. M-TEER MitraClip. 5 steps to the procedure. What are the key complications here? Well, you're using a big 24 French sheath in the femoral veins, so venous access complications are a thing. Major bleeding requiring transfusion.
Incidence.
Varied in studies. Everest's high-risk cohort was over 13%, but the big TVT registry was lower, around 4%.
Prevention?
Ultrasound guidance for access is key. Preclosure techniques, like figure-of-8 sutures or devices, can help seal the vein afterwards.
Arterial puncture by mistake.
Can happen, less likely with ultrasound. Might need a stent graft if it does.
Then the transeptal puncture itself. Crossing between the atria.
Need to aim posterior and superior. If you go wrong, you can cause pericardial effusion or tamponade.
Treatment.
Drain the fluid percutaneously, reverse anticoagulation. Surgery is a possibility if needed.
Thrombus formation. Clots.
Risk is higher with severe MR AFib or coexisting mitral stenosis, either native or caused by the clips. Clots can form at the puncture site too.
Prevention.
Keep the ACT in that 250-300 second range during the procedure.
And if a clot forms on the sheath?
Best to remove the sheath, maybe try and suction the clot out.
Okay. Single leaflet device attachment, SLDA. That's unique to TEER.
Yeah, where the clip only grabs one leaflet instead of both properly.
Yeah.
Incidence maybe 1.5% to almost 5% in different series.
Who's at risk?
Patients with flail leaflets, large regurgitant orifice areas, or small mitral valve areas.
What do you do if it happens?
Options include trying to place another clip, surgery, or just medical management. Often the leaflet detaches acutely anyway.
Prevention is about careful imaging during placement.
Absolutely. Meticulous TOE guidance during grasping and deployment. Live 3D is really helpful. Confirming grasp and multiple views is vital.
Can you redo MitraClip successfully after SLDA?
Yes. Studies suggest placing another clip often works well.
What about bumping pacemaker leads during the procedure?
Need to be careful maneuvering the catheter near existing leads. Check the relationship with fluoro and echo.
Residual MR after MitraClip? Still having a leak.
Yeah, if it's moderate or more O2+ at discharge, that's linked to lower survival.
Treatment. More clips.
Placing additional clips is the main strategy if the gradients and anatomy allow. Occluder devices or other techniques are less common backups.
On the other side of the coin, iatrogenic mitral stenosis, making the valve too tight.
It can happen. Predictors include a small valve area to start, 4 centimeters here, using multiple clips, high baseline gradients. A mean gradient over 5 mmHg post-clip is a worry.
Prevention. Careful patient selection.
Yes, and appropriate imaging. Try to use the fewest clips possible. Measure gradients in MR after each clip. Balance reducing the leak with not creating too much stenosis.
When to stop adding clips.
General guidance is avoid more clips if the mean gradient hits 7 mmHg and the valve area is under 3 centimeter fills.
Last one for M-TEER. Iatrogenic ASDs. Holes left from the puncture.
Very common, actually. Persistent defects seen in maybe 40 to 80% of patients a month later. Larger catheters, longer procedures, sheath movement, high LA pressures contribute.
Should they be closed?
Recommended for high-risk patients. Large defects, big shunt, low oxygen, RV dysfunction, risk of paradoxical embolus, aneurysmal septum, pacemaker leads nearby.
But does closing them actually improve outcomes overall?
Interestingly, the MITRA's trial looked at closing them 1 month post-MitraClip and found no significant improvement in clinical outcomes. So routine closure isn't standard.
Okay, finally, let's touch on TMVR, transcatheter mitral valve replacement. Less common, more complex.
Generally, yes. The review has a useful table summarizing complications. A major issue specific to TMVR is LVAO, left ventricular outflow tract obstruction.
The new valve blocking blood flow out of the ventricle.
Exactly. It's a big predictor of poor outcome and a common reason patients get excluded. Predicting the risk with gated CT is essential.
What do you look for on CT?
Things like the anterior mitral leaflet length, the predicted neo-LVO2 area aiming for 200 millimeter minutes, device dimensions, aortometral angle, septal bulge.
How common is it?
About 13% in one international registry, highest in valve and MAC procedures.
So strategies to deal with it. You mentioned lampoon.
Yes. Laceration of the anterior mitral leaflet to prevent outflow obstruction. Uses RF energy to split the leaflet.
And Batman.
Balloon-assisted translocation of the mitral anterior leaflet. Moves it out of the way.
Other options?
Alcohol septal ablation for a big septal bulge, either as bailout or preemptively. Radiofrequency ablation, sesame septal scoring, even surgical cutting techniques like MitraCut.
These leaflet modification techniques sound crucial for TMVR.
They really are expanding the possibilities for TMVR. Initial lampoon results showed decent survival.
What about afterload mismatch after TMVR?
That's when the LV struggles acutely after the MAR is suddenly fixed. The ventricle isn't used to pumping against normal pressure without the leak as an outlet.
Management.
Pharmacological support inotropes, vasodilators, careful monitoring of RV function and pulmonary pressures.
And other TMVR complications mentioned briefly.
Valve embolization or migration might need snaring, another valve inside, maybe, or surgery. Cerebrovascular events, DOACs, seem comparable to VKAs for prevention here, and paravalvular leak can happen after TMVR too.
Wow, that's a comprehensive tour through a lot of potential challenges. It really underscores that managing these complications effectively is just vital for the success and growth of these transcatheter therapies.
Absolutely. It takes a whole multidisciplinary team, cardiologists, surgeons, imaging specialists, nurses working together, and the field keeps innovating, developing new tools and techniques to make these procedures safer.
It certainly does. So the final thought maybe is, as these amazing technologies keep evolving and we start using them in broader patient groups, possibly sicker or more complex patients, how will our strategies for predicting, preventing, and managing these risks have to continue adapting and improving right alongside the tech? It's a constant evolution.
That's exactly right. A fascinating field to watch and crucial work for patient care.
Indeed. Thanks for joining us for this deep dive.